So, yeah, we have the discussion, and Murat, are you going to lead that as a
Thank you.
The clinical world and myself?
So some questions is coming, but my first question goes to Professor Jean Lavic. He has suggested that the survival of cervical cancer is decreasing in the last decades, and the tumors is getting more aggressive. So, do we have any solid data to say that, or does it related to screening and coverage vaccination crisis recently seen in France, or some HPV mutations happened? Why the tumors are more aggressive in the last decades, Professor Jean?
Yeah, thank you for the question. So, in my point of view, many progresses were done in France in screening and in vaccination, even it's not perfect. So, in consequence, the incidence of cervical cancer is lower than we observed a few years ago. And it keeps only the bad cases. The bad cases, when I was young, I remember we were very frightened when we see very young women, but it was very rare. So naturally, in my own department, that we see is quite only young women. The incidence, the global incidence, decrease in France, but there is still very young women with aggressive tumor, very aggressive tumor, with a gap between infection and big cancer, a very short gap. So these tumors are not able to be screened by virology and so on. And in my point of view, the biggest problem for this tumor is that we treat this aggressive tumor as we treat tumor in older women who were screened. So, in my point of view, we need to be more aggressive in the treatment for these young women. Probably, we have to begin the treatment by chemotherapy, neoadjuvant chemotherapy. It's the only solution. As Patrice showed us, when we treat with neoadjuvant chemotherapy for the biggest tumor with the objective to conserve the fertility, we observe very good results. So we have to do the same, in my point of view, for the young women we see now.
Yeah, I mean, the concept in the cervical cancer treatment has really moved to more and more minimal invasive surgery and less radical surgery. Despite the latest publication of Pedro from MD Anderson canceling the laparoscopy in larger tumors, we are going less radically. And this is a very good advantage for many developing countries, actually. Sentinel lymph nodes, laparoscopic surgeries, because at the end, why do we screen the ladies? To prevent invasive cancer and also to prevent morbid radical surgeries. And I think neoadjuvant chemotherapy has a definitive role here, not only in fertility saving, but also in Africa. We don't know how many cervical cancer surgeons we have. Really, it is the capacity. And the neoadjuvant, we don't also have a radiotherapy. So neoadjuvant chemotherapy will definitely have a role in the developing world and to try to make in a lesser radical type A, type B hysterectomy, maybe in Africa. So there are some questions. I will give the microphone to Sylvia, but before going that, maybe another question to both Jean and Patrice, to both of you. How do you feel about pembrolizumab, this new immunotherapy in cervical cancer? As I see in your slide, it is as a trial, but maybe it will be a standard treatment in recurrent cases. Currently, the recent European guidelines, EMA, approved it, I believe. And of course, to Patrice, How about the vaginal versus abdominal? And how about the circulage during the surgery or at the time of pregnancy? Yeah, a few comments from you, please.
Jean, you want to begin?
Yeah, we can hear you.
Yes, just a word about anti-PD-1 treatment. Actually, in France, it's just in the frame of trials. So we are waiting the results of the trial. So,
but it's really, the results are promising. It will be a game changer.
Yeah, but only in case of PD-1 positive cases. It's not always the case. And even if the first results are very interesting, so we are looking for a long time the follow-up. Yeah.
Patrice, about the
thanks. Concerning also PD-1 anti-PD-1 treatment, we have some experience because we use it for about 3 to 4 years in Switzerland. We had some good response, but usually the response is quite short, and after 6 to 8 months, there's progression of the disease. So, in our experience, it's efficient treatment, but as many of these treatment, you have progression of the disease in several months afterwards. So it's only for recurrent cases. Concerning the question you answered me, you asked me for radical tracheotomy. I think the vaginal approach is probably the best approach because it preserves easily the uterine artery. And that's the main interesting point when you want to preserve radical tracheotomy. You have to preserve the vascularization of the uterus and try to preserve the uterine artery. When you do this approach, this treatment through abdominal approach, you are going to cut the uterine artery in vast majority of the case, and so you probably decrease the vascularization of the uterus. So my opinion is that vaginal radical tracheotomy is still a very good option for this patient. The main problem is that people are not very trained to this approach, and that's the limit of this treatment. So probably the best in the future will be to make this treatment in very centralized centers who are trained to this approach, and that's all. And concerning the cerclage, that's a good question. Usually we perform the cerclage at the time of the surgery of the radical tracheotomy because it's quite easy to perform it when you have all the uterus fundus that are in front of you, and it's very easy to put the cerclage around the uterus. But some teams are not doing at the time of the radical surgery and perform it when there's a pregnancy. I think it's difficult to answer this question. In my opinion, if you do it at the time of the radical tracheotomy, you prevent another surgery during pregnancy. So probably, in my opinion, it's the best option. But I know that it's a good discussion.
Sometimes after the surgery, they cannot become pregnant, you know. And how many months? That's my point. Usually, I did several tracheotomy cases, and usually I prefer if they become, because it's around 50% the chance of being pregnant, 50 to 60%. So this is a debate among the surgeons. And we have some questions.
Yes, yes. Maybe I just add some point. Also, one thing is when you perform the surgery through the vagina, you have less adhesion inside the abdomen. So probably also you decrease the risk of infertility. And in our experience, the patients that were infertile after radical tracheotomy has mainly, in vast majority of cases, stenosis of the isthmus. If you do a dilatation of this stenosis, patients get pregnant in the few months afterwards. So
Yeah.
the problem of infertility in our experience with radical vaginal tracheotomy is very low, and maybe there's cases with patients with endometriosis or other causes. But the risk of infertility induced by the radical tracheotomy is very, very low, and it's only stenosis of the isthmus.
Yeah. Some more questions that I will leave the microphone to Sylvia, but my final question goes to Haitham. How do you believe, how do you think the surgery and the treatment, if you compare HPV positive cases versus the negative cases? I think positive cases is a little bit larger in gynae-oncology, I mean, and much easier maybe compared to the HPV negative cases maybe. And do you have any experience on screening of oropharyngeal carcinoma, because the publication numbers are increasing very rapidly to screen the oropharyngeal cancers?
Okay. So regarding surgery, first of all, I would like to say that the prognosis of HPV-driven oropharyngeal cancer is much better than that of cancer related to tobacco. And this is observed whatever is the treatment, surgery, chemoradiation, etc. Most patients with HPV-driven cancer have a small primary and big lymph nodes that have a cystic appearance. And as the primary is small, they can be offered robotic surgery, which is less morbid than classic surgery because you remove the tumor transorally. You don't have to split the mandibula. So this is one important point. Regarding screening, we have a huge problem with screening. Unfortunately, to date, we are completely unable, I repeat, we are completely unable to screen oropharyngeal cancers. And this is a major problem. This is why I think that all of us, we have a big role in raising awareness among our colleagues and among the general population regarding this type of cancer, to be able to diagnose them as soon as possible, as stage 1. This is the best scenario. And finally, there are some ongoing work about screening, and the most promising work are based on the detection of antibodies against E6 and E7, which can be detected a long time before the discovery of cancer. But of course, this is premature data, so they need to be consolidated. Thank you.
In this sense, Christine Clavel was asking about the possibility of P16 and HPV integration and methylation. What do you think is the
for screening?
Is marker? Yeah, I guess so. That
yeah, for screening, I'm not aware about recent strong data using this technology. The only thing I'm aware is about antibodies against E6 and E7, and some scientists try to see if they can use HPV DNA, circulating HPV DNA, which seems to be maybe also a promising way to progress. But I think that the most efficient thing is to raise awareness in the first time. It's easy to do. We just have to communicate.
Yeah, in this sense, I was asking you as well about the role of dentists, no? That they are seeing, let's say, healthy patients, and I don't know if there is any role for them.
Yes, I think that they have a role. I agree with you. Huh? I think that when you see a patient with a pharyngeal discomfort or something which seems to be very benign or mild, but that does not disappear with time, that lasts several weeks or months, I think that he should be referred to an ENT.
Thank you. I wanted to ask to Patrice, I know that we are talking about France and Europe, but as I work in low resource settings, I am very concerned about the population living with HIV, where we see even for the management, these women, that they have the chances to be screened and we detect the CIN3. They do a LEDs if they are lucky. But even with the LEDs, the recurrences of the disease is very high. And we are doing a lot of molecular work now with John Dorber trying to see what's happening with these services. And my question is, seeing the type of treatment that you are doing that preserves fertility, do you think that women living with HIV with a diagnosis of CIN3 should be treated more aggressively as if there was a stage 1 disease? What would be, or what is your experience with this population?
That's a good question. We have experience of patient, HIV patient, but there's not very large experience. In our experience, these patients have, in fact, the rate of recurrence of CIN very high, but the rate of progression to invasive carcinoma is quite low. It's the same probably in the general population, and it depends mainly on the treatment of the HIV. If the patient have good treatment of HIV infection, they have very low risk of recurrence of progression to invasive carcinoma. So usually in this patient, we know that there's high recurrence rate of CIN1, CIN2 lesions, but we treat only CIN3 lesions, and we do classical treatment, that means conization, let's conization. But for us, HIV infection is not a contraindication for example, preservation of the fertility in early cervical cancer, if the patient have a good control of the HIV infection.
Maybe one comment to Patrice here. In contrast to head and neck cancers, almost 100% of cervical cancer is HPV positive. And HPV positivity actually, my friends, does not change our surgery or chemotherapy or radiotherapy, given that they are almost the same tumor we are talking about. But for HIV people, not the treatment, not the surgery, but prevention is much more relevant. I see in many HIV people are not linked to national immunization programs. This should be very crucial that HIV, once you are HIV positive patient, you should immediately also look to cancer screening for cervix and HPV vaccination, if not done before, as soon as possible, to prevent these aggressive tumors. I mean, I see in many HIV cases that they are simply ignored because of the different problems in the body. We just simply forget the screening and vaccination, but this should be automatically done upon diagnosis, I believe. And vaccination in this population, there are good data showing immunogenicity and efficacy, whatever the age, even if that their CD4 counts are low. So I suggest to make our strategy on primary and secondary prevention, rather changing the treatment of CIN.
Thank you. I don't know if there is a response to that, but I would like to raise here the issue on anal cancer, because there is a lot of activity now with all these trials being stopped and identifying that we need to go for treatment. And I would like to ask Didier Riedmüller to give us, if he can, a sense of how is anal cancer now in France and how they see the results of the recent trials.
Okay, I will give to Mrs. Voronov the pleasure to talk about the anal cancer incidence in France, and it's quite very concerning because this cancer is not also it's not already only a female cancer, and the incidence is growing up both for men and for women.
Thank you. Yes, yesterday I showed you a slide with anal cancer trends in incidence, and you could see that incidence is raising about I don't see very clear, but 3.3% between 2010 and 2018 in the men, and by 2.7 in women. And I showed you that the rise is most important in women age 50-70. And we link this with the same trends observed in cervical cancer and with HPV associated link.
Thank you. I think it's an important issue in many countries. We are seeing this upgrade of increasing incidence of the disease in both sexes. Do you think there is any, or can anyone comment about what can be the impact of the Anchor trial in a sense that they stop early the randomized trial in the US because they consider that management of the early lesions detected in screening clinics should benefit of an early treatment. And I don't know if this has had any impact in France. It's very recent result, but it's any comment on that?
In my country, I can give you an example from Turkey. Of course, there is no screening for anal cancer, but especially for recurrent CIN cases, recurrent HPV positive cases, I think awareness of the males, husbands, are important. That they should also be, careful about anorectal cancer or oropharyngeal cancers. Currently, we cannot recommend screening with HPV, I believe, because the most efficient screening is high resolution anoscopy, and it's not available in many centers. I mean, even if the man or the female is HPV positive and you think something exists in the anus, you need a high resolution anoscopy, and this is not easily available. That is my point.
Maybe the subgroups of men having sex with men, which is an important percentage, or people living with HIV are those targets for this screening. And I see the hand of Patrice. Maybe he wants to add.
Yes, I just want to add one point, because this problem of anal cancer is quite important, and we had performed a study in Switzerland with 3 groups of patients. It was female patients. One group was a normal patient attending to the clinic for benign pathology. Other group was HIV patient, and third group was patient with CIN lesions. And in these 3 groups, we do anoscopy, and in case of abnormality, we do biopsy, or also in all cases, we do brush of the anus and test for HPV. We are now evaluating the result. I'll probably give you this answer in the 2 or 3 months that are coming, and I think it will be interesting. But already we can see that there's quite a large number of anal pre-invasive lesion in HIV group, and also in the patient with HPV lesion. And we know that many patients harbor also HPV in this area. I don't have right now the numbers, but I can give you probably in 3 or 4 months, and it will be quite interesting.
Jean-Luc?
Yeah, Yeah. I have a comment. Actually, in France, hello to everyone. Actually, in France, we have some recommendations for the screening of MSM or HIV positive MSMs, and these recommendations are written, I think, in the Rapport Morla, and we take care to propose a screening for anal precancerous and cancerous lesions in these vulnerable populations. Now there are reflections also in France to try to introduce anal cancer screening. And in Reims, as well as in Besançon, we try to introduce, okay, now this is research, but to propose a systematic HPV testing and to triage then with cytology HPV positive cases, and then to propose high resolution anoscopy to this very specific population with an HPV positive sample and an alteration of cytology. But this is just ongoing studies, and okay, we are looking about this, but it is not really organized now. But I think there is an opportunity to identify the most at risk patients, male or female, to try to triage them and to make anoscopy, high resolution anoscopy, to a limited proportion of people. Because probably, as you know, HPV positivity at the anal level is very, very frequent.
Yeah.
So,
thank you very much, Gianluca. There is a hand raised by Jean Levesque. And I see that there is a lot of responses in the chat. Thank you very much for those that they keep on responding. Jean, you are silent. On ne peut pas vous écouter, Jean.
Okay.
Okay, now.
So sorry, Mirat, but I disagree with you, because I think that anoscopy, high resolution anoscopy, is a very, very difficult examination to perform. Very difficult, much more difficult than colposcopy. So in our practice in Rennes, we observe that precancerous anal lesions are beginning 10 years after precancerous cervical cancer or lesions. So in our own practice, what we do in women more than 40 years, we perform cytology, anal cytology, especially in women with vulvar lesions, HPV related. And clearly, we found many lesions, AEN1, and less often AN3. And for high-grade anal lesions, we do anoscopy. In my point of view, it's not possible to screen women with anoscopy. It's too hard, too difficult.
I mean, I fully agree. We are talking about the same. We did a systematic review. This point is very important for the attendees. In ESGO, as will publish very soon, in vulvar pre-invasive diseases, I believe if a patient has especially VIN, it was around 10 to 15% concomitant anal lesions. So vulva is, very similar to anus. And if you have a vulvar lesion, then anus is really, really very high risk. This is true. And of course, for screening, the most important criteria, the acceptability of the screening tool by the patients. You cannot make abdominal tomography to screen the lung cancer to everybody, So this is the problem of the anal cancer. The experts of anal cancer say that, the gastroenterology expert, it's the only high-resolution anoscopy that they can give diagnosis. So anoscopy is not the screening, but for diagnosis after pap smear or after HPV So you just select the patient, and for diagnosis at the end, they need, that's what they say, high resolution anoscopy. But we are at the same point. I agree that we cannot screen. Even colon cancer cannot be, today the people do not accept colonoscopy once in 10 years.
Yeah, I think we can see that this is a very hot topic, and we need to devote some time for the next meeting maybe to talk more. But we need to close the session because we want to keep the schedule ongoing. But I do appreciate very much all these discussions and all the comments, and I thank you again for the overview we have had on clinical management of our cancer patients, and I appreciate very much all the involvement of everybody. Murat, I think we can close now the session.
Yes, sir. Yeah. Thank you so much, dear friends. It was a wonderful session. See you. Bye-bye.
Bye.